Hardware access management, where we start the structural heart summit, and these are my disclosures. So in fact, these two angiographic pictures, we can make out what was the problem. In one, there was a high puncture, and you can see the bleed, and the second, it was a low puncture, and below the femoral head. So, and sometimes you require cover stent to manage these situations. So idea is to avoid these unnecessary problems and hassles by exactly knowing the anatomy and guiding the procedure well in a safe manner. So this is the site of the puncture has to be in the middle of the head of the femur, and we can appreciate the two kind of landmarks. One is the bifurcation of the femoral artery into SFA and profunda, that is the lower margin, and the upper margin is the inferior epigastric artery. And in the middle of the head of the femur, we can compress the vessel, and that is why it is important to locate that area and puncture there. And we can see here how the vessel is diving deep into the pelvis. You can't compress if you puncture little higher. So it has to be between the inferior epigastric artery and lower in the SFA, above the bifurcation. And when we look at the inguinal crease and then try to guide our puncture, it may fool you many times. You can see here you are looking at the femoral crease, but what you see here, in the fluoro, you are so lower down. So we have to combine your inguinal ligament surface anatomy with the fluoro marker if you don't have ultrasound guidance. And if you have ultrasound guidance, that is the best. So these were the days when we used to guide through angiogram, the puncture. And now we have many evidence which supports that ultrasound guidance is far better than the fluoro punctures and any other way of doing that. So you can see here the femoral head and the bifurcation. This is the longitudinal section. You locate at the bifurcation, you go cross section just above the bifurcation, and you can appreciate the femoral head. You can see the femoral head so well visible, and then once you make it cross sectional, you can see the circles, and the two circles goes into one, and there you puncture. The puncture has to be just at 12 o'clock. If you miss it or angle it, you are not going to close it properly through the prostyles, because that will not able to capture the vessel, the segment of the vessel appropriately. This is how we prepare the entire setup in a sterile manner. You can see the fluoro cover. We take jelly inside that. We take the probe inside, and then rubber band, or you can use gauze piece to just cover it, and then you are ready with the marker on the probe corresponding to the P which is there in the monitor. You go cross sectional after looking at the size, looking at the basically the place where you have to puncture. Now, and the distance has to be akin to the distance which you assume from probe skin to the femoral artery. That distance you maintain from the probe to where you are puncturing. And you can see here 12 o'clock puncture. And the vessel, the flow which comes here, it is not a spurt which we usually see in our femoral artery puncture. It will never come in a jet. It will come like this. And you have to take the wire, and the wire has to be taken inside in a under the fluoroscope. You can see here it is going this way. It can create problem. So you need to see where it is exactly going, and this advancement has to be under fluoro, the wire. So once we are done, we can reconfirm that we have punctured rightly, and this is the distance which I just told. We have to come little down when patient is obese, and this is a case which I will just show where we had used 4 prostyles and 1 angioceal to manage. Just briefly, I think we have some time, 4 minutes. I will run the video. This is the ultrasound guided puncture which we did, and both sided ultrasound guided puncture, because this was an endovascular procedure where we required 22 French access from left and 18 French access from right. So it was totally endovascular. You can see the bifurcation. Then we go a little up, and you see the circle here, and you can see the femoral. This is the femoral head. This is the circle, and then we are puncturing right at 12 o'clock over the artery. and then flow comes, you take your wire in, and after 2 axes, you see how we take the prostyle in. So prostyle has to go over the wire. You have to make the track before by dilating it with a artery forceps, because the suture has to go in and it should not be somewhere entangled inside the tract. So once you reach this wire exit port to the skin, you remove the wire, and this 45-degree angle has to maintain. This is one of the most important thing. Once the blood starts coming, you go to 11, because we are using 2 prostyles here, and then you lift the lever and retract the device so that it hinges against the wall. Then your plungers are down, foot plate down, then you pull out the sutures, give a quick cut, and then you go little in, the foot plate down, and then you come out, harvest the sutures. This suture harvesting is important. You don't have to change the relationship. It has to be clamped with a artery forceps together. If one is tightened with other, then this knot can happen in the tract, and then you can really fail. You may not push the knot to the vessel wall. And once you are done with this suture harvesting, you can reintroduce the wire, and you can here see the wire exit port is there. There is a two white markers. There is a exit port. So you reintroduce the wire. Please allow me when we are 8-9 minutes. And once it is inside, then repeat the procedure again with the second. You are done with 2 prostyles in the left. Now we are doing 2 prostyles in the right. So there are 4 prostyles we have taken. Now we did the endovascular procedure. So we have this, basically we have done the device. You can see here the endovascular graft of 22 French axis. We have done the procedure, and we are coming out. You can see here the upper limb is, the upper body is deployed, the lower ones are deploying. And once we are done, this is how we take over the blue wire. We take the knot pusher down. Yes. Knot pusher down. And since it was bleeding with 2 prostyles, we give 1 angioseal. So we have a lot of other talks are there. It will be amply clear to everyone how to deploy this. And then we could finally close with these 2 prostyles and 1 angioseal on one side and 2 prostyles on other side. And this is the final picture after the deployment of the valve. So this is the final result. You can see here, it's flowing well, the vessels flowing well closed, and the result was good. Thank you so much for the patient hearing, and I hope we will have some more discussions in sites.
Thank you, sir, for the excellent demonstration of the entire technique, because everybody knows that the mortality happens from femoral complications most commonly. So, sir has already highlighted, but I would like to just quickly recapture that ultrasound guided has given us the additional advantage of puncturing at the top of the vessel, because we are very habituated to fluoroscopic punctures and tactile punctures, but we need to puncture at 12 o'clock for large vessels. Otherwise, this 16 French, 22 French, if we puncture on the side, we might miss some part of the vessel. Then just one more point I would like to add is that now we have Manta device also, where a single device is enough for the large bore access managements also. Thank you, sir.
So we can have some discussions, our chairpersons, Dr. Siddiqui.
Yeah, I think as we go, if you go by ultrasound guidance, older people are used to doing angiographic guidance, but I think a combination of both is what is really most accurate, because in ultrasound guidance, sometimes in almost 20 to 24% of cases, there's a high bifurcation, and you may really miss the femoral head at that time. As you said, you can see the femoral head sometimes, but sometimes it may not be very well seen when people are obese or something. So at that point, angiographic and ultrasound combined together may have a better option sometimes. And that is what I tend to follow more or less, most of the time.
Sir.
Dilip, on another thing is the under fluoroscopy control and micropuncture is very useful technique you used to do before also. Thank you very much
Sir,
indeed for presenting.
one more point needs to be discussed. What is the flip side of ultrasound guide puncture? Maybe Dr. Rajiv, Dr. Anmol, Pratap, anyone can give their comment. Flip side of ultrasound guide puncture. You see any flip side, or what we see that it's 100% the way to go?
As I said, higher bifurcation. That's the one main.
Any other
important flip
points in
side.
the field? Yeah.
Let's
Dr.
make it in another way. What are the common mistakes we make during ultrasound guided
Yes,
puncture?
yes.
Yeah, I think. Yeah.
This is drastically, this way they drastically reduce the rate of peritoneal hematoma. This is very advantage of that thing.
So, can I comment? So one thing we need to be very careful about doing when we are doing the ultrasound guided puncture, that we need to see exactly the tip of the needle, where we are actually puncturing. So you often don't see and go on puncturing, then you are not actually puncturing on the right point. It may be up or it may be down.
Yes.
So it is important to visualize the tip of the needle, that it is indenting on the 12 o'clock of the artery. So that's one thing we need to keep a mind on. And second, I would like to emphasize that when we are putting the prostar, it's important to make the track as well with a forceps little bit. Otherwise, you would not be able to push the knot down up to the arterial wall. So making a little bit of space is also important. So these are the two things that I would say.
Yeah, I guess as rightly said, the groin is an Achilles heel for the structural heart because it is a large bore. So my usual take is whichever technique you are doing it, but master it first. Don't try to flip on one access technique, then another access technique, and not master of everything. So whichever technique you are good at it, confident and reproducible, you should do it. Ultrasound, yes, it is a learning curve, but you should learn ultrasound guided technique. It is very useful. And calcium, sometimes if your angle is little tilted and all, you might miss an entry wall calcium. So you have to be little more careful, because if you take a proglide or prostyle in that calcified area, there is a good chance you might fail with your closure. So you have to be more careful.
Yeah, excellent point. So in line with that, the previous comment and this one, normally our practice is to put around 1 centimeter cut in the skin and then to properly dilate the subcutaneous tract so that we can really deploy the knots at the vessel wall. And another advantage we have is the pre-procedural CT. From the pre-procedural CT, we have a fair idea where is the bifurcation, how is the calcium distribution, and that also helps. But ultrasound, the flip side is, I think, a learning curve. We have to do some cases imperfectly to learn.
I think
the technique.
Dr. Mishra sir and Dr. Majumdar and Dr. Anmol clearly highlighted. If we are not looking at the proper things like tenting, the vessel has to tent 12 o'clock. So it is indenting. It means you are puncturing there. So if you're puncturing and blood is coming, but you can't see the tent, it means you are not puncturing at the site which you are seeing. That is the flip side. And I think Dr. Menon will also give a little more insight. So it can be combined with your fluoro. Exactly, once you are there, just in fluoro, that you are in the same, you are not going beyond the femoral head or lower down. Yeah, Dr.
So, just add one point here. Since you are often having a second axis, suppose you have a left femoral axis as well, you'll put a J wire right at the femoral head where you want to be.
We can do
and that can be seen in ultrasound very well, and that could be a good guide as well.
Yes.
Yeah, few things which we are doing differently nowadays is one, CT, we are trying to actually look at the inferior epigastric also. So we know previously we used to just check the bifurcation. Now we look at the inferior epigastric. So we know exactly where we want to puncture on the femoral head. So as Dr. Siddiqui just mentioned, our general practice is always first localize on fluoroscopy because we are more comfortable. We just make sure where the femoral head is, and then use the ultrasound to make a puncture at 12 o'clock position. The second thing is slightly scraping the needle so that it's a big challenge. Many times we can't see the needle tip, and that makes a significant difference. But this CT planning to know exactly where we want to puncture has significantly helped us in trying to know where to do it. The last point is nowadays we have gone to ProGlide with one angioceal, but in case when we are using 2 ProGlide initially,